Hello, and welcome to another episode of the Improved Healthcare Podcast. I'm your host, Rich Greenhill. Today, we'll discuss clinical informatics and COVID-19, perspectives on technology and the care continuum with Ms. Jennifer Leos. Jennifer is an experienced nurse leader in clinical informatics with more than 20 years of experience in healthcare. She has a diverse background in multiple care settings, focusing on strategy and development of programs, as well as processes for health IT initiatives. Her skills include health IT procurement, implementation and maintenance, as well as optimization. Jennifer is a registered nurse with a Master of Nursing in Informatics. Her credentials include she's a certified public health nurse, a certified professional in healthcare information management systems through HIMSS. She's a Lean Six Sigma Black Belt in healthcare and IT. In addition, she's an American Nurses Association certified informatics nurse. Welcome, Jennifer. How are you today?
Doing fine. Thanks for having me here, Rich. Very excited to be here.
Thank you. It's so good to speak with you again. It's been a little bit of time. So I want to just start out by helping everybody understand some of the basics around clinical informatics. So if you would just define clinical informatics for us and tell us how it supports healthcare delivery.
No, absolutely. Well, I will tell you just the broad overview of what clinical informatics is, but just know that there are many facets to this. So there's a way to look at it. One is definition. The other way to look at it is the value that it brings. And then the other way is just kind of like, what is the role of that? And that's going to really be dependent on the setting that you work in. But in a general overview, clinical informatics is an application of informatics, where is information technology is bridging to deliver healthcare services with clinical technology, information technology, and clinical services. So it's the three kind of together. The way I look at it is like an intersection of these three sciences coming together. And in nursing, for example, nursing informatics, as you know, nursing is an art and a science. And so if you can think about like the care delivery you get just from being a nurse, and then just incorporate, the data knowledge of information sciences, and then also incorporate technology, that's a high level view of what is informatics definition. But then the value that it brings is basically these people who work in these roles are those people delivering care and incorporating, this is what we do with workflows. This is what we do with analyzing information that we're receiving from patients, and what we're going to do for actionable data, designing how we're going to do the whole care continuum from, admission to discharge, outpatient care, like how does that work to make it easier for patient experience, and then even population health outcomes, and even the clinician-patient relationship. So there's a lot of communication focus in informatics, and also a lot of interoperability, but interoperability with all of these systems together where it's understandable to the clinician and it is a value to the patient. So to me, that's the best way to look at the informatics definition and then the informatics value.
That's a great definition. I'm thinking here from my time in quality and performance improvement, a lot of the times when we are asked to do a project, we're looking at a dashboard or looking at, data, and leadership will say, hey, we've fallen out on a metric here, so go focus on improving that. So it seems like the folks in your role and types of folks in your role, you are really the foundation for how we look at data and determine what to work on. So it's pretty important role.
Yeah, and it has a history. So I wanted to kind of jump in and tell you a little bit about the history. So the other point that I was making was that some people, depending on the setting that they work in, it's going to be viewed differently. So back in the 90s, informatics was kind of not as known as it is now. Now it's actually established in the American Nurses Association. There's, credentials that you can get now that weren't there before. And in fact, in the late 90s, early 2000s, there wasn't really even like a master's degree that you can get that says informatics. It was, concentration or here's a class of it. Not that it's established back then the way that it is now. But one of the things that were bringing it out was, I don't know if you remember being in the military, there was something called CHCS, those DOS systems.
I do.
All they did was keep data like patient information, right? Like that's it. But if you wanted to write something, you have to like print out a template, write it out, and then, that's it. There's no entry into this DOS system. So a long time ago in the late 90s, early 2000s, this was pretty much healthcare, right? And so one of the things that happened with informatics, clinical informatics, was that breakthrough policy about, this is what we want to do. We want to become more interoperable. We want to be on EMRs. We want to move from paper. And then these are the initiatives you get for meaningful use, for example. And so informatics was highly, I guess, regarded the IT could not do that without physicians and nurse leaders and people being able to kind of connect all those dots. And so for a long time, nursing informatics were just viewed as those people who just do an implementation or just do a training or, that kind of thing. But it has evolved since then. But depending on where you are in your settings, you might be viewed as this, or you might be viewed as the person who's, helping with patient experience.
For our listeners here, because I think that a lot of us that have different views of when we hear informatics, things pop into our head. I oftentimes will think nurse informaticists like yourself, or chief medical informatics officers. And I know that y'all work together. And so very important role. And I can tell you from a quality standpoint, you are vital to us being able to do our work in quality. So, well, as we think about informatics and how those systems work together and we deal with data, how did COVID-19 impact clinical informatics, or did it impact clinical informatics?
It put us on the map. I think that due to COVID-19, there was a big gap that we had, I'm just going to throw telehealth as an example, mobile health management is another example, and just communication to wide populations and being able to get that data back and what do we do with this? What's our process to report back, or what are we looking at? All of those things came to play. And then there was, people knocking on informatics doors like, help us. And then we worked together because informatics is not a standalone entity. It really does have to work with quality, the specialty physicians and specialty cares, has to work with patient experience, personnel and things like that, clinic staff. And we were able to really do a lot of stuff in a short amount of time to respond to COVID needs. Even things as small as would be informatics related. For example, we had surges, right? So there was surges of patients coming in and what do we do about isolation? How do we chart that? What do we, put them in the halls? What do we do? We don't have enough technology to admit people in the ED. What do we do? So all of those things where informatics was starting to play let's use mobile to kind of help with that. Let's, help with operations and getting mobile management here in these tents. Let's do this, that kind of thing. So COVID brought in one way, this big gap for the technology or the clinician side, but then it also revealed another big gap, which was from the patient side, all of these things that we could make accessible was not accessible to everyone. Those gaps were also revealed.
It seems like with the COVID, this is something that would help folks like you and I trying to implement change. And that's really, it reset the culture, right, of collaboration. Because in the past, I can remember trying to work on projects where you're trying to get people to work together and do certain things or adopt new technology, and you hit a wall every time, right? And so you mentioned telehealth. So I think most folks know, but a dam burst with telehealth. And so it's being used much more. Do you think those trends will continue once we, round the turn with COVID as far as informatics?
My educated guess is that absolutely. There is value to using it. I'm trying to remember where I got these numbers, to quote some, but I'm just going to give them in vague. There was some statistics that telehealth, at least nationally, was something under 5 to 6% of visits, and mostly because it wasn't billable. It was not a priority for healthcare, even though it was there and it could really help rural areas and things like that. After COVID, that shot up. I think it was 25% more being used, and that was just a short amount of time. And so if you think about that, there's no way I could see that going backwards. And then especially there's more initiatives now that some telehealth visits are going to be able to be billable now. It's not that it's a lot of money, but it's just now it's becoming part of a normal healthcare avenue. And especially we saw that in behavioral health and also in some primary care visits.
That's true. I think it's funny. I saw I had my first telehealth appointment ever last year. And you think, well, gosh, you work in healthcare. You haven't done this before. But I felt a little strange about it and, talking to the doctor over the camera. But, it turned out to be okay. And it made me more comfortable, not have to go in during the pandemic. So just fascinating. Well, let me ask you this. So as I think about your role and think about informatics and data, knowing what I know about data, there's this saying in statistics that you use statistics and data to tell lies and damn lies. So with that, given that we're in this age of information bias and bias in general and issues, and so COVID also has raised discussion to a high level about health equity. And what do you see as the main, or do you see see any main concerns with information bias? And is it related to health equity on any level?
That is a great question. And it's one of those questions that we could spend a lot of time talking about. But I will give you some information just from, the experience that happened through COVID. Absolutely. There is, like I mentioned before, there was some revelations of data that we realized like during the pandemic. One is, access. So equity, we want to look at like access to care or access to maybe getting this telehealth visit or, things like that. And these are systems that were in place, and systems meaning sometimes it's not controlled by healthcare, but it's controlled by other institutional systems, if you know what I mean. The systems that we do have control over, which is, government funded items, actually put some barriers highlighted to us. Like, for example, telehealth, it was never really built before. So these were barriers for people, for institutions to make this a priority, to make this accessible. And then there's the things like where people who maybe want to come in but can't come in because they don't have a device, to telehealth or connect. So what do we do about that? And then just outreach for remember I mentioned a little bit about population. So here's the populations that we have data about, but we don't have the best data because we haven't been collecting the right questions, like social determinant questions. We've been collecting, insurance questions. We've been collecting, like, where do you live right now? And we have this data for 5 years, but who's updating this? Who's doing all of that? So there was a lot of gaps between just regular things. But then there was also some interesting things that I saw is data that we were getting from outdoors, like, for example, health information exchanges, public health data that people were getting. And people were translating this data without thinking of all of the variables. It can go two ways, Rich. It could be, it's a good thing that we have this data, right? Like, we need this information so we can be safer. And then there's the other part of it is, okay, if we're going to act upon this data, we want to make sure we're not introducing any type of harm to patients, inadvertently doing this. Mm-hmm. I'll give you one example. We heard out through the news and we, even through various states that there was a high percentage of patients that were becoming COVID positive or not getting a treatment, and they were, Black and Hispanic population. We want to reduce all of that, but we need to do a little bit more digging, because the other part of it is like, I hear the data here, now I want to have this reaction, but when I put the data into action from this end user level, what am I now saying to the end user? So for example, if we solely go by just the race or ethnicity and didn't have another data point, or if we're doing that, like what are we teaching the end user nurse, the end user person who's like calling someone and saying, hey, based on your race or ethnicity, we would like for you to come in and do a COVID test because data from public health says this particular race is highly positive. You know what I mean? And so without other risk factors. And so think of being that patient. So that's the whole thing about like the whole continuum of care is like the patient experience. So now you're the patient, you're hearing this, one, you're getting scared. And number two is like, how is that possible? I haven't left my house in 20 days. I'm not you know what I mean? Right. So it's not a one size fits all approach. It's a multifactorial approach. So you want to take the data, you want to analyze it with the variables. You want to make a mindful impact by, putting in like, oh, my outreach is going to be this based on, for example, zip codes. So that's just an example of some of the things that were noticed.
Well, that's interesting because the thing that I heard you say is, you have to have the proper context for data, and you can't look at one data point, race, ethnicity, gender, and make a decision, even though, because all races are not a monolith. The other thing that you brought up around the exposure of other issues was, as you were talking about people having access, is broadband access. I mean, that's something squarely in the social determinants outside of healthcare. But if we're going to offer telehealth, I mean, have we considered the people who may not be able to afford broadband, or maybe they don't have internet literally because they don't have the lines laid, or fiber lines or whatever. So here's a thought, or public health data. When I was in the hospital, we do a lot of reporting out right to the state for disease data and those kinds of things. Do you think that there is more openness now to use public health data? Do you think that that's an output of this, or do you think that that's still kind of a ways away? I mean, we don't have a great public health apparatus in the country, but do you think that's something that healthcare leaders could think about? What do you get from the state, and what could you do with it?
That's a great question. I do think that in the future, now that we've had these lessons learned, that we do need to be more open to looking at the bigger picture of data, especially when we're looking at the public health, like what we had in COVID, right? This was a virus that was attacking people. It didn't care like if you lived in Avenue B versus, 59th Street. I do think, again, having that multifactorial approach where we're making sure we're analyzing the right data, because remember, we do live in an era right now that was the other gap that we saw, is that not everybody had healthcare. Here we are going through this horrible pandemic. And even though we were making, as much effort as to outreach and to, get people to get the care they needed or get tests, not everyone had access to healthcare. There are other ways to get data, besides just if you have healthcare or not. And so I think we need to, in the future, start looking at, this is our current state and this is where we want to be in the future, is like, having healthcare access to everyone. But in the interim, we need to leverage data more. We need to become more interoperable in ways that we can. So health information exchanges, for example, in the past had just focused on contracts, between hospitals to say, hey, this person came in through the emergency room. I want to give you a notification of that. That's a great way to kind of maybe leverage a problem like this, is to think of like, okay, so maybe we want to flag people who don't have health insurance and maybe do an outreach, and say like, hey, let's put you on a program or something. There's other things that I think we need to start thinking about differently. And also the way we did outreach before, now that we know that we're moving towards more technology, maybe we can create some grants and programs for people who don't have a device or don't have Wi-Fi.
I've even heard of some initiatives where people are invited to use telehealth at their church, right? So the churches, sometimes the healthcare ministries or the health ministry will have a room that people can go. I mean, so definitely other things that we could do. Well, that's great. So as we get ready to wrap up, what are some lessons for the future that we could take on as healthcare leaders or educators? What have we learned that we could put into practice in the future? Maybe even around culture or otherwise.
For me personally, there was a lot of lessons to have been learned. And then, being in this great field of informatics, you get to see things in different perspectives because, I'm very fortunate to get to work with multidiscipline groups and teams and leaders to kind of, work through problems. But some of the things I will say, culture. Right now, we have a healthcare culture that was designed for people who could afford insurance. How is that working for us now? It's a very complex system. There are many facets to it. So how can that become more inclusive to removing those disparities of access? And how can we, bridge together between systems a little bit better with data? And I think a lot of that started to happen with the Cures Act. I think that's going to be a catalyst of more to come, but I still think there's more bridging to do. So that's one for like the interoperable piece and accessibility piece. The other part of culture is the person piece. So some of the things that we've learned or what we're seeing is like, okay, how are we using data? It can be so great, or if used in a wrong way or interpreted in a wrong way, it might be harmful. So how can we mitigate that, or what do we do? So there are things to do. One is information. There's something called the Tiger Initiative, where this was, again, from the beginning of health informatics, is like incorporating that into new hires, into curriculum and things like that. So let's really do it, because right now we have pieces of that system, but we don't have that all incorporated. So one, give people the tools and the knowledge of like understanding a perspective. Number two, make sure that you are integrating clinical teams and looking at healthcare in a different way that is going to be different perspectives. So instead of having one or two perspectives, you have 10 perspectives looking at a problem, and we can really minimize gaps. And then the other thing about culture is just start making this a standard, including the health equity lens or the diversity lens in everything you do, because healthcare is for everyone. And if we want to have a population that's going to be healthier, then we need to look at the population as a whole. And so right now, integrating this data, working together, I think we're going to be able to leverage that.
You're absolutely right. There's a guest I had on earlier, a friend, a colleague, and we were talking about using machine learning. And one of the things is machine learning in a lot of ways looks backwards to tell you something about the future. But looking backwards, if we have disparities and they are baked into the data we've already captured, it sets us up to perpetuate those things. And so you're absolutely right with making sure that there's inclusivity of perspectives and voices so that we truly get to see the whole picture and not just this, insurance focused, reimbursement focused picture, but a wellness sort of vantage point. So, well, Jennifer, I certainly want to thank you for taking time today. It's always good to speak with you. And, I think this was just very enjoyable. So thank you so much.
And thank you, Rich. I enjoyed being here. And thanks for letting me speak on your podcast. I just wanted to also give you some kudos about it. I really love what you're doing. I think it's going to be so impactful and helpful, and it's much needed. So thank you for being in this space.
Thank you, Jennifer. I appreciate that and look forward to talking to you soon.
Thank you.